Welcome everybody. Welcome everyone to the first webinar in the series of 2024 for the Red Lion Group. I'm David Davis, I'm the proud chairman, and I'm absolutely delighted to introduce someone who will be very well known to many of you, Professor John Nicholls. Let me introduce John Nicholls. So Professor John Nicholls is the pouch king. He's been referred to informally. There are two very good reasons for that. The first is that he invented the pouch along with Sir Alan Parkes back in 1976, 77, 78. So he's the father of the pouch, and someone to whom we are all grateful for those innovations way back when that have basically changed our lives. And the second thing is he's prolific during his surgical career in terms of the number of pouch operations that he did, estimated to be around about 3,000, which makes him probably the originator of around about half the pouches in the UK at the moment, something like that. It's a very gross estimate, but certainly a prolific and extremely experienced and talented surgeon. And from that point of view, we're very grateful to him for what he started. He is the Professor Emeritus Consultant Surgeon at St Mark's Hospital, where he has a long tradition, obviously. And he's the Professor of Colorectal Surgery at Imperial College London. So he's keeping his eye in. Delighted to hear that. And we are delighted to have him as a patron of the Red Lion Group charity. So without further ado, ladies and gentlemen, thank you for dialing in. Thank you for joining us tonight. I'll hand over to Professor John Nicholls.
Well, David, thank you very much for that introduction. It's always nice to be at meetings of the Red Lion Group, and I've watched your organization over, well, the whole duration of its existence. And I've usually, with pouch Red Lion Group meetings, when I've had the privilege to be present, I've talked about pouches as the agenda of the meeting. Obviously, it tends to be very much focused on all aspects of the pouches. But and the last time I gave a talk, I did talk about the pouch and the history thereof. But I thought this time, having been invited by Gary to give a webinar, I thought I would like just to tell you about my time as a colorectal surgery, not for any personal reasons, but just to say that during the 40 years that going from the late 70s right up to the first decade of the 21st century, so up to 2010, that 40 years, during that time, the most extraordinary technological revolution happened. And that is the main reason for wanting to talk about the subject, because it was an astounding story, and we were all in it. You were in it, we were in it, trying to help the patients. And all the time, things were changing in so many ways around us that it was a constant process of adapting and trying to contribute also to the changes as they came up. And it was the most exciting time. And I expect that for the next 30 years, the rate of change and the rate of benefit of technology will simply increase. I don't see why any other option, but that it will increase, and perhaps things in 20, 30 years' time will be almost as unrecognizable as they would be now to somebody who practiced, say, in the 1960s or 70s and then retired at that time. So that's why I hope you'll find this talk interesting. And if you don't, that's my fault actually. But I'm going to try and just give you sort of my side of what I think I saw, and with that will be some comments about the world in which I happen to practice, and also about the history of surgery from the very beginning very briefly a rapid run through 3 or so millennia of medical, I suppose you'd say, development and evolution. And I hope you will not. I hope you'll find it interesting. And if you don't, please let me know, because I don't want to be unnecessarily boring and technical. But there will inevitably be quite a lot of technical terms. But I realize that people who've had pouches are an educated, from the medical point of view, an educated group of people in society, and they know a lot about medicine and the difficulties of taking decisions and the relationship or interrelationship between the patient and the disease and the technology, for example. So here goes. I started 1978 as a consultant and happened to be a general surgeon, which we all were in those days. But shortly after, from the late 70s into the early 80s, general surgery, which included just about every anatomical area of the body, except the brain, the bones, and to some extent the kidneys. But most of the rest of it, the general surgeons, when surgery was needed, were the people who dealt with it. But that very large group of diseases became fragmented, or as specialization was increasingly demanded and indeed necessary in order to be able to deal with ever increasing numbers of patients, but increasing knowledge of diseases in different organ systems, which did require then a specialization. So the general surgery split up into thoracic, lungs, and esophaguses, as it were, upper GI, gastrointestinal, lower gastrointestinal, that was colorectal, and breast and endocrine, and transplant. And colorectal surgery in this country really emerged, as it did from everywhere in the world, really, as a major branch, but a branch of general surgery. And the good thing about colorectal surgery from the surgeon's point of view is shown in this slide, really. A lot of the abdominal emergency work in concerned the colon, the rectum, the small bowel. So it formed the bulk of abdominal emergency surgery, which, of course, as a practitioner, you want to be working, you want to be occupied. And this was actually a very good element of colorectal surgery. And a very important aspect was the fact that the cancers in the colon and rectum are much, much more likely to be curable than they are, and things have changed a bit, but even then, now, more than cancers in the stomach, particularly also the pancreas and the bile ducts. So we were dealing with an organ, namely the large bowel, which had a good prospect of cure when cancers developed. The prevalence of anal disease in society is very, very great. It can cause an awful lot of trouble to people, and in some instances ruin their lives if they have persisting infections or very severe hemorrhoids and so on. And so it was a wonderful opportunity to deal with those conditions to the general benefit of almost all the patients, provided you did it properly. And then when surgery was necessary, inflammatory bowel disease came to the colorectal surgeon. And this actually was professionally very interesting, in as much as in so doing, we were working with gastroenterologists and in cancer with oncologists. So we were not an isolated group of people. We were part of a bigger team and a collaborative team where each side more or less understood the other and respected and sympathized with their particular problems and so on. So these were very good reasons for going into colorectal surgery. But like so many things, one's career followed as much the line of chance as it did in any other deliberate maneuver by the individual. So I was very lucky. I went to Cambridge University and came down to the London Hospital and worked with Professor Ritchie. There he is. I never saw that photograph before. He certainly didn't look like that when I knew him. He was a bit older. And Charles Mann, who is here. Charles Mann was also not only a surgeon at the London Hospital, but he was also a surgeon at St. Mark's. And that was the first sort of time I heard St. Mark's mentioned. And Charles Mann, he's died now, sadly, but I have a lot of respect for Charles Mann. He was a very bright, intelligent person who was a committed trainer and teacher of the young. And I remember doing his outpatients at St. Mark's on the Saturday morning when he collected young senior house officers in surgery from all around London. And we would go along and do the clinic on the Saturday morning. And at the end of it, at about 1 o'clock, we'd all go into one of the rooms when the patients had all gone home, and he would give us an hour's tuition on a Saturday. And he was that sort of person. And then I had the good fortune to become a senior registrar at the London. And one of the segments of the 4-year period was a year with Alan Parkes, who became Sir Alan. And at the time, and indeed still now, amazingly, but at the time, in the field that we're talking about, he was the most inventive person one can imagine. He made so many contributions to surgery, but colorectal surgery in particular. And he was indeed an inspiration. He was knighted in his capacity as chairman of the BMA Consultants Committee, but he would have, I'm sure, have been knighted anyway for his actual contributions to surgery specifically. And then I spent a year in Germany with at Heidelberg as an Alexander von Humboldt Fellow in the Department of Surgery there, whom the professor which was Professor Fritz Linder. And he was a very fine person. It was an extraordinary place to go. I wanted to go to somewhere, not in any anti-American way, but people went to the United States in those days. And I thought, well, why don't I do something different? So I went to Heidelberg, and where in our hospitals, you had 2 consultants and 3 or 4 registrars and a houseman as the team. There you had something rather like a military division of 10,000 troops. You had the professor in the middle, and on his left and right side, there would be 3 professors on each side called Oberdoctors, Oberärzte, who ran divisions within the surgery, and they would be looking at the morning when we came to the 7 a.m. meeting, it was winter and summer, for the whole department to be assembled in the great auditorium there. There would be 120 assistants, all in white kit, sitting there in their rows, while right at the bottom in the middle, looking at them, would be Professor Linder and his henchmen on each side. And above Linder was a portrait on the wall behind of Professor Kirchner, who was a famous surgeon in the 20s and 30s, who actually looked, so he was one of the most savage surgeons you could possibly imagine. So we were all looking at this scene of the chief with Kirchner glaring at everybody behind him. But so that was all what I think now is less prevalent as a trainee in our country in surgery, particularly. Namely, there was a huge element of inspiration that was engendered in the young trainee by the senior people under whom that person would be working. And as you might sort of hear, I have great immense respect and pleasure thinking of these people who were led by their example, and you knew who you worked for, and you knew which team you were in, and you had a sense of belonging and loyalty, which I think has not disappeared, but is much, much less strong now than it used to be. So having said that, I joined the staff of St. Mark's as a consultant. And that was a similar sort of wonderful place where everybody, it's a small place, but everybody was at his or her own frontier. Many of those people had worldwide reputations, and they all worked in a happy environment where courtesy and common interest prevailed. To such a degree that the idea and the functioning of what now has become a word, a sort of password in medical parlance, multidisciplinary care, not that St. Mark's invented it, but they might have done, but certainly they were the predominant hospital in the country, I think, looking back on it, that had got an integration of consultant specialist knowledge at the highest degree from different subspecialities within the overall specialities, so pathologist, radiology, imaging, therefore, and medicine, gastroenterology, and surgery, that revolved around the patient and was concerned to offer a considered balanced diagnostic and therapeutic package, as it were, to each individual patient. We even had, just looking at this photograph here, a psychoanalyst on the staff to look after or to contribute to the management of people who had degrees of neurosis, which unfortunately is really quite common in patients with bowel symptoms. So this was a wonderful place to have found oneself as a consultant. And I can't quite see all the picture here because we've got photographs down the side. I don't want to go on too long with it, but here's Sir Francis Avery Jones, who was at St. Mark's as the first physician in the 50s and 60s, and he came and did a couple of sessions of work there and never asked for a penny for it. Here was Sir Ian Todd, who was president of the College of Surgeons. Here is Basil Mawson, the great pathologist who made so many contributions, and Clive Bartram, the radiologist, and Leonard Jones, the gastroenterologist, and James Thompson, my friend and colleague. And it was a wonderful place to work. And that also allowed one to be in contact with people who were always at a frontier. Now, over the last 40 years, there have been extraordinary advances in all these fields. And I shall sort of make some comment about most of them in this talk. But they're all important. Technology, of course, has transformed the scene. Informatics is part of technology, but it means if now you can stand at the foot of the bed, you've got your phone, and if you want to have references to what you think you're looking at and look at the literature, what is known, you've got a bit of time, you can just get the papers up on your phone pretty well immediately and verify a fact that you might want to confirm, or something like that. And then research has become much, much more professional and organized, and that has been very important. The diseases themselves, we've obviously understood more about them, we've got right now into molecular biology and genetic testing and so on, which has been applied also to the diagnosis and identification of bacteria. So nucleic acid taxonomy of bacteria, particularly, of course, relating to the intestine, where there are many, many different species, 1,000 or more, has identified something like 500 species of bugs that were never heard of before. And so that's an amazing effect of technology. And professional communication or interprofessional, we've got meetings, we've got societies, we've got collaborations of all sorts, multidisciplinary, but also multi-hospital research, which has amplified the size of samples and size of patient groups one is treating, has contributed greatly to accelerating the acquisition of knowledge. And all this has been underpinned by regulation of performance, so that doctors are aware of the limitations of their practice and that the moral obligations that they have, as if they weren't before, they jolly well should have been. But there has been, I think, well, a necessary, but also a very morally proper and acceptable form of regulation. I've now got 3 slides which set out really to demonstrate the early part of the second millennium I'm dealing, or the first millennium, from about 120 AD, right up to the mid-19th century. During which time, that's a long period of time, but during that time, there were very few advances, although they were major when they occurred, in knowledge, medical science, physiology, and anatomy, but which nevertheless, despite these huge increases in knowledge, did not, probably meant that a patient being treated in the early part of the first millennium, Anno Domini, in the time of this person Galen, all the way up to the early 19th century with Dr. Liffranc, who was a French surgeon at the Salpêtrière in Paris. That whole period, probably a patient presenting then as opposed to now, as it were, in the early 19th century, would not have had a much different prospect of cure or indeed a diagnosis. In other words, medical science had not really notably improved, as far as we can surmise, survival and cure of diseases as they presented. So we have Galen, and nothing really happened for 1,000 years. And anyone who disagreed with what Galen said about anatomy, about diseases, etc., was treated rather as a pariah who was effectively going against the orthodoxy of the time. But then in the early 16th century, so the 1500s, you got several things happening. First of all, the idea of this Paracelsus, who was a traveling monk who would go around treating patients, but he proposed the idea that diseases actually have their own identity. They're not just a disturbance of the 4 humours that Galen had: phlegm, blood, bile, and some other element. But they were clinically identifiable entities, and he identified gallstone disease as a discrete medical circumstance. Simultaneously with this was the study by Vesalius, who came from what we now call Belgium. He went to Italy, where he did a lot of work in dissection and so on, and Titian, the painter, produced the anatomical drawings, which went into the book that Vesalius published, founding modern anatomy. Whereas Galen would say things like, the blood went in and out of the liver like the tide, and the functions of these things were whatever Galen said. Vesalius had put the anatomy, the foundations of modern anatomy in such a way that then when we come on to is William Harvey here, he in the next century, the early part of the 17th century, in 1628, published a book based upon research, laboratory research, which he did on tortoises and measuring vessels and so on, which made him come to the conclusion that the blood went round the body as a circulation, forced round by the pumping effect of the heart, and where between the arteries, which he identified on the way out, and the veins, which he identified on the way back, hadn't got the means of identifying things as small as capillaries, but he said there must be minute connections between the arterial and the venous system. And within a short time, microscopy came into medicine, and the capillaries were demonstrated. So by this time we've got the foundation of anatomy, the most basic of physiological fact, namely that the blood circulated, and then a series of interesting developments, practical, but also leading to other fields of medicine. But Ambroise Paré, a French military surgeon who was serving in the wars of the late 16th, early 17th century, invented the surgical ligature and demonstrated that it was an effective thing. You could put a tie around a bleeding vessel, or if you were doing an amputation, you could cut the leg off, cannonballs flying all over the place, and simply ligate the vessel with some string rather than putting the stump into burning molten pitch, which is what used to be done, which in itself probably caused the death of quite a lot of people injured and treated in that way. So the surgical ligature worked. And then this character here, Morgagni, at the end of the 17th century, he said he was professor of medicine in his university for Bologna, I think, for the whole of his lifetime, almost from his late 20s all the way through to his death. You might say Italian style in a way, but he said, we have all these people dying, and what we need to do is to look at the body after death, carry out what became called an autopsy, which means I see with my eyes what actually happened. So a morbid pathology came from time of Morgagni, and then with John Hunter, a Scottish surgeon who came to London to work in the anatomy school in Covent Garden with his brother, William Hunter, became a very famous surgeon and really founded the whole science of experimental surgery. And he made many contributions, but the idea by this time had been, we look for a phenomenon, we apply the scientific method and devise a set of possibilities for that phenomenon, and we start to try and see which of these are more likely to be responsible according to experimentation. So by the time the 19th century came up, a lot was, the groundwork had been laid, but as I said, treatment was not necessarily all that effective. And Lefranc had a series of about 20 patients whom he treated for carcinoma of the rectum, which was treated before anesthesia by excision of the tumor and so on, with at least his results were reported, and they were not good, with very few long-term survivors, as you might expect, and a lot of people with damaged sphincters who were thereby incontinent. So, but things were moving in such a way that when Wells and Morton, Wells was an American dentist in Connecticut, and Morton was an American doctor in New York. Wells and Morton, I haven't got time to go into the details of this story, but in the early 1840s, Horace Wells, using laughing gas, which has now apparently come back in as a recreational drug, laughing gas was being used at the time as physical and organic chemistry was developing, and he applied it to dental extraction, which he carried out in his surgery, and they gave the patient the patient inhaled nitrous oxide. He pulled the tooth out, and the patient woke up, and they couldn't believe it. And this was, one of those huge moments in human history, really, which changed the whole of medical practice. Amplified then by Morton, who took ether, which again was organic chemistry, was producing these substances, and ether was one that probably had anesthetic properties, and he used it, or went to professor's surgery at the Massachusetts General Hospital with his bottle of ether, which he just did not disclose what it was. It was deceitful in that sense. But he said to the Professor Warren, this could be of service. Would you consider me giving it to one of your patients for an operation? And Warren did, and he carried out an operation removing a cyst from a patient's neck with Morton at the top end, dripping ether into a cloth, which the patient was then inhaling the vapor. And the operation went well, and the patient woke up, and Warren turned to the 50 or 100 young surgeons watching this procedure, which is how operations in those days were transmitted as far as learning and teaching was concerned. And he said, "Gentlemen, this is no humbug," he said. And that was something like October 1842. And by Christmas time, ether had been used in Vienna, Berlin, Paris, London, Rome, you name it, just because it was available. And anesthetics started, and surgery expanded as many more patients became entered into the ability of medicine to be able to accommodate surgical practice for whatever diseases they might have. And one of the consequences of the increase in the number of operations that resulted from an anesthesia was the increased mortality and morbidity due to what was called hospital infection. And these three people here, Louis Pasteur, born in Arbois in the French, in the Jura, and Semmelweis from Budapest, and Lister born in Upminster, and spent his main part of his time as professor of surgery in Glasgow, and then came down to King's College Hospital in the late 19th century, in the early 20th century. And there's a statue to him at the top of Portland Place, because that's where his house was, where it isn't the General Medical Council, but one of those organizations now had its offices. And between the three of them, Pasteur, the most brilliant of all medical researchers, who wasn't actually a doctor, he was a medical doctor, he was a chemist, identified and demonstrated the existence of microbes. And he also, during his life, understood the idea of immunology. So you challenge a person with some sort of vaccine and produce what became realized as antibodies, which then gave immunity to that patient. And he developed vaccines as well as identifying bacteria, their presence. And Semmelweis demonstrated that these agents, which were bacteria, were transmissible from one person to another by bodily contact. And in so doing, in his practice in Budapest, where he worked in the hospital there, in the labor wards, where the mortality, if you were a young mother who'd just given birth and you got a temperature, in those days, in the mid 19th century, you had a 25% chance of dying of puerperal fever. And he reduced the incidence of puerperal fever down to a level that was actually going on in the parallel ward that the midwives ran. But the midwives didn't have the medical students coming into their wards, whereas Semmelweis did have the medical students coming into his wards, and they were coming from the pathology department, where they'd been acquiring ghastly bacterial contamination, transmitting it on then into the population of young mothers in Semmelweis's unit. Anyway, that human transmission was his message. And Lister devised a whole system of reducing the presence of, or reducing the amount of contamination in the air through microbes during surgery by spraying the operating theatre with phenolic acid from a sort of machine called a donkey that converted the liquid phenol into a fine spray, and demonstrated with added wound care a fall of mortality from falling off your horse and breaking your leg with an open skin covering. So that was be called a compound fracture. The mortality of which, before he imposed his method, was something like 80%. He reduced that in 2 to 3 years to a figure of about 20%, demonstrating, not that everybody followed him or agreed with him, but demonstrating again the huge influence of bacterial contamination that was responsible to a considerable extent for this very high mortality. And his idea of antisepsis, where you assume the bugs are there and you spray them, was followed by von Bergmann in Germany. His view is if they shouldn't be allowed to get there in the first place. So antisepsis that Lister created was then developed further by von Bergmann and called asepsis, so that the hospital, the operating theatre was kept as clean as possible. People had to wear protective clothing. Surgeons had to scrub up before operating, and they had to wear, well, gloves came in a bit later, but the wearing of gloves was all part of this. And that is where now, from that time on, surgery has remained a therapy where the aim is to prevent the incursion of bacteria, asepsis. And then, just not to take too much time, but Robert Koch, general practitioner in Germany, he started identifying bacteria and photographing them. And he would ask things like, in winter, where do these bacteria go? And he discovered that they form spores. And when the weather improves, the temperature goes up, they come out of their spores and become pathogenic again. And Koch made a huge contribution to medicine, particularly bacteriology and tuberculosis, and actually rose from being a general practitioner to the most senior professor at the Charité Hospital in Berlin. And then this, if Pasteur was one of the greatest top, I don't know, top 2 or 3 medical people, medical researchers, Virchow was in that category. Here was a man who was a pathologist, who studied inflammation with his colleague Conheim, and they worked out all the sequence of events at the cellular level of how acute inflammation develops, how the repair of damage leading to scar tissue formation, all these basic things, thrombosis, and also the idea that you can look at a piece of a tumor and you can say that it actually is distorted normal tissue. And by virtue of how things look down the microscope, which by this time had become quite sophisticated, you can diagnose diseases down the microscope through histopathological analysis. In other words, modern histopathology, which is the bedrock of the diagnostic process even today. It may not continue with AI and imaging systems and so on, taking the place of the pathologist looking down the microscope, but this is still where we are, and Virchow was its originator. And then moving on very quickly, actually, because of time, we have Billroth in Vienna. There's a Prussian who was did the first successful gastric operation. We have Kraske, one of his assistants, who developed the first proper operation for rectal cancer, doing it from below, removing the rectum from below, but that was aiming to do more than Liefranc had done 50 years before by taking more tissue around the tumor. And Halsted, who was an extraordinary character, an American, became a professor of surgery at the Johns Hopkins Hospital in Baltimore. Johns Hopkins was a multimillionaire who built a hospital and set up, he got 4 famous doctors in the States to be the first, create the first hospital where proper research would accompany medical treatment. And thus academic medicine was formally founded in Halsted's time. And Halsted made huge contributions to surgery, and particularly to the concept of the cancer operation, which has to have not only adequate removal of the primary tumor, but the whole, as far as is anatomically possible, the whole of the vascular and lymphatic supply to try and remove the whole thing en bloc. And that's, again, to a large extent with many tumors, still the principle today. And Ernest Miles, a London surgeon, was the proponent, along then with Kirchner in Germany in the early part of the 20th century, the 1930s. This is Kirchner, that face looking down at us all in Heidelberg. You can see that that there was a tradition of if you don't do things properly, you'll really be in trouble. These 2 surgeons developed the standard cancer operations for rectal cancer in the early part of the 20th century, followed by Dixon at the Mayo Clinic, who added to the strategies of Kirchner and Miles, which left people with a permanent colostomy. He added to that development the idea that you could safely join the bowel together and preserve anal function. So that was this set of discoveries and development in the latter half of the 19th century created a situation where at the beginning of the 20th, it was said probably going to your doctor is going to do you more good than harm by that time. But up to that time, it was doubtful. And here I've not mentioned Landsteiner, an Austrian pathologist who discovered the ABO blood group in the early 20th century, for which he got the Nobel Prize, and from which blood transfusion was rendered possible. And then in the late 30s or 40s, I think it was 30s, he discovered the rhesus blood group, for which he got a second Nobel Prize. As a result of his work, blood transfusion became a practical and safe option, rendering surgery more, much safer and reducing what in those days, with a major operation, for example, by Miles or Kirchner, we're talking about surgical mortality of 20 to 40% of patients undergoing these operations through then proper post-operative care, management of bleeding and blood transfusion, and of course, understanding of nutrition and water and electrolyte balance. That surgical mortality reduced considerably over the 20th century, and now it's below something like 1 or 2%, depending on the, of course, the circumstances of the pathology in the first place. But by that time, we come on to the modern era of the recent history, and here are some people, many of whom were interested and affected in the surgery of ulcerative colitis and Crohn's disease, but also cancer. And I won't go into the, I haven't got time to take your time too much, but we have Cattell, who was a great American surgeon, biliary surgeon, Miller, who applied colectomy to patients with ulcerative colitis and brought down the operative mortality of just doing an ileostomy for them by taking the disease out. The mortality tumbled over the 5 years he collected his cases from something like 30 to 40% to less than 5%. And Ravitch, whom I had the privilege of having dinner with years ago, was a courteous and interesting person to talk to, and Bacon, these were great figures of American surgery. And Niels Koch with the Koch ileostomy, which was applied to patients who'd had a proctocolectomy with a permanent ileostomy. But the Koch, as I'm sure many of you will know, the Koch technique allowed life with that ileostomy to be ameliorated because it, on the whole, if it was successful, avoided the need actually to wear an appliance. And then Alan Parks, so many things he did, but he, of course, was the founder of the pouch, and John Gallagher, whom I forgot to mention right in the first slide, was a very important figure in British and indeed world surgery, whom I personally had the privilege of knowing as a very young registrar, and I was inspired by him. And then my friend Vic Fazio, who died about 2 years ago, and Roger Doswa, whom I'm still in contact with. These people all added to modern surgery in a way that makes it easy for us to see now how it developed. So what I'm saying is that over that period of time, from Galen all the way up to, say, 1970 or 60, there had been significant improvement in the results and diagnosis and the results of treatment. But even then, there, when we were starting, when I was starting in 1978, there was, compared with where we are now, we were in another world. So we didn't really, this is what it was like being a surgeon in 1978. You didn't really know your results, at least very few people did. There was no sort of idea of continuing professional development. You were pretty well on your own with not very much accountability. And for some surgeons, there was a conflict and balance between public and private practice. And these three things at the end also slightly cynically refer to private practice, but I don't mean to be cynical at all. But it is amusing and true to reckon or to be aware that people talked about the 3 A's, which was you have to be available, affable, and able, in that order, it was said, with, in a slightly humorous way and a cynical way. But it was not a people were free really to do more or less what they wanted. And not only that, but when I started, this was about the limit of what we could do to for the patient. We could take a history and do an examination, and you could look of 25 centimeters, if you were lucky, up into the rectum and the distal sigmoid colon. You often couldn't get round the bend at the top of the rectum, which would mean you could see no more than 15 centimeters. So, you were relying on contrast radiology in the form of barium enema to diagnose any tumors or abnormalities, the extent of inflammatory bowel disease, for example, above the level of the rectum. And then with the stomach, barium meal was about the only real way of identifying gastric carcinoma and ulceration and so on. There was histopathology, of course, but that was about it. And only clinical history taking and examination and histopathology have survived because of technical developments. And here it is. So here suddenly, or in the 70s, we had colonoscopy, and you could see the whole colon, and you could diagnose cancers. Not only that, you could find polyps that before this invention here, snare polypectomy, those patients with polyps would have to have an abdominal operation, the bowel open, the polyp removed because it was thought to be precancerous, and the bowel closed and everything, a major operation therefore, some of those closures of the colon leaked, and patients, not very often, but they did die from time to time. But snare polypectomy got rid of all that surgery for benign polyps, just like that. Shinya and Ishikawa. And then CT came in, Godfrey Hounsfield here, working in West London. He produced a system of X-rays which transformed imaging into a sort of three-dimensional thing. And then MRI, or magnetic resonance, came in. Mansfield and Lauterbur, they both got the Nobel Prize. Hounsfield and Mansfield were both British, and magnetic resonance is the most accurate way of identifying the spread of cancer in a localized lump of tumor and where it is invading or not surrounding structures. An anal ultrasound in the field of colorectal, Clive Bartram, a consultant radiologist at St Mark's, converted or the probe that was used for abdominal ultrasound into one that was suitable for looking at the anus itself. And that again has transformed a lot of colorectal diagnostic workup. So these extraordinary technical developments were followed then by engineering systems applied actually to the conduct of surgery. So laparoscopic, robotic, transanal microsurgery, here created by Gerhard Beuys in Germany, where you look up the anus with a great big scope which allows the placing of long instruments down each side of it to be able to do operations from below. And sacral nerve stimulation for patients with incontinence and stapling to join bits of bowel together were things that have transformed are not only, well, the previous slide, diagnosis, these have transformed treatment, and the formation of intensive care units from the early 1970s onwards with such support systems as parenteral nutrition, which some of you may have had to have some parenteral nutrition. Oh, I'm awfully sorry about the jumping. But these general intensive care support systems have transformed management, and leading then to Henrik Kellett's introduction of the idea of fast-track recovery. So patients are encouraged to get out of bed. They are fed up before they get to the surgery. They they receive relatively physiological amounts of intravenous liquid, and anesthesia is controlled in such a way that their recovery is enhanced. And this has again resulted in patients going out of hospital within a very short time after operations that 10 years or 20 years ago, they might have been kept in for a week to 10 days or more. So this has made a huge difference to medical practice. And then research has gone through considerable modifications in terms of the design of studies and the idea of applying for funding with the submission of proposals and so on, to make a research career something that is based upon a fully supported system, and not just an amateur type of trying things out just for the sake of one's curiosity, but a very important, obviously, a form of structure that has rendered the acquisition of data and its analysis something that has been hugely effective in not only basic science but also in clinical trials. This is just to show, and I'm going to move on very quickly, that all these trials of giving radiotherapy to patients with rectal cancer before any surgery is contemplated result in a far lower incidence of local recurrence of the tumor afterwards. This is a huge discovery, and all based upon prospective studies that have all come to the same conclusion. So clinical research as well as basic scientific research have been very central to the current decision taking and the introduction of new research protocols. I just moved on to say that rectal cancer, which I've had a particular interest in, has gone through a very considerable evolution into low morbidity and improved results of reduced local recurrences I've referred to. And we are now in a position where it may be that giving chemotherapy and radiotherapy together before any surgery is concerned, it may well be that, as indeed it is the case, some patients will have a response which may seem to be complete and thus permit the surgeon before contemplating surgery to say, we watch this patient and wait and see what happens, because some of them may not need surgery at all. So that is again, a major part of the management of rectal cancer now, and it's a transformed field where the prospects for a patient with rectal cancer are now immensely better than they were 20 or 30 years ago. And Alan Parks with the pouch, just a couple of comments about the pouch. It's been a pity for me, or to see some of the what has been a successful operation for many patients throughout the world with lots of good studies, and albeit there is a fall off of retaining anal function, but nevertheless a very high proportion of patients retain anal function in the long term, better in the context of an inflammatory bowel disease unit. But during your lifetime with the pouch and so on, you will be aware but we found in certainly in Britain, which of course, if you do research, you will find things out. But most, something like most of the surgeons doing pouch surgery only do one pouch every so often, as you can see. And 25% of surgeons who were doing pouches, as it were, when one looked at the data from central NHS databases, 25% of them had only done one in the previous 5 years, which which was a disappointing finding, and we perhaps might have that out in a question if there's time after when I've finished. But here it's just a slide showing that the nurses have got very much involved with setting standards of how patients with inflammatory bowel disease are managed when they come into hospital, and what sort of tests they should have, and so on. And that's nearly there, David. This is a slide showing that in the current world we live in medicine, the data available to follow rapid changes and so on has been extremely sophisticated, and increasingly so. So you've got these world databases, mainly American-based, a huge contribution to the world. You've got the idea of evidence-based medicine led by Archibald Cochrane, who created the Cochrane Library and database, which is full of systematic reviews for any doctor to see, and meeting societies and publications. So that is, I think, that is my last slide of note. I'll just sort of finish off with this last slide. This is Battle Abbey, which is nearby where we live. I hope I have at least demonstrated the amazing progress that has been made in the last 30 years, and that it will only accelerate. But the concern that a lot of doctors have is the question of losing sight of the clinical method and the patient. And you hear this with, as you retire, with people who go to the doctor and so on, and don't seem quite to be understood in what they're trying to say, and thus to preserve common sense in looking after patients and be sure that what you're doing is linked to what their disease is and what their main complaints are. Thank you very much. I apologize for going on a bit.
That was absolutely brilliant. Thank you very much indeed, John. I have to say, I think the temptation, I think, is always to produce the slides on and concentrate on pouches, but you chose to do something much more ambitious this tonight for us, which was a much more holistic view, going way back when, of the advances in colorectal surgery that have led to and enabled yourself and Sir Alan Parks to be able to do the pioneering surgery that you did, which is absolutely fascinating. And well done for condensing it into so few slides in such a short time as you did. Well done for that. So, right, questions for you. I'm a little bit handicapped because I can't see the questions, but there's been a few submitted by text. So let me start with a question about pouch longevity. This has come from Sophie. Do pouches have a lifespan? And she's asking the question because I've actually got a quote here. It does not seem uncommon for long-term pouches that have been healthy for a long time to fail and lead to a reversion of the pouch. And I highlighted the question does not seem uncommon because I think I just want to make the point that when you run a support charity like the Red Lion Group, and you have a Facebook group which is hugely successful and growing by the day, it does attract questions which are from people who are looking for support, which is absolutely natural. But when you get a quote like "does not seem uncommon," I think we do have to keep a perspective a little bit. But anyway, what's your thoughts, Prof? Do pouches have? Sorry, I'm going on a bit. Do pouches have a lifespan?
I don't know about lifespan, but it's been known for a long time that there is a steady decline in the prevalence of anal function after pouches if you look at a large series of patients. Now, if that's jargon, what I'm trying to say is if you start with, say 100 patients who had a pouch operation, and let's say 2 years or so, there are still happily, or there are 90 to 95% of those patients, so 90 to 95 of those patients still with anal function. But you look at them at 10 years, and that will have fallen to about 80 to 90 of them. And probably, and indeed going up to 20 years, there's a sort of steady fall off. And our figures in this country for, if you like, continuing anal function at 20 years, I think if I remember rightly, because we had a pouch, national pouch database.
Yeah.
It was something like 80+% of patients still had anal function at 20 years. If you look at the Mayo Clinic's data, and I just don't quite understand it, but that figure was about 6% of patients had lost their pouches. Now, still over 90% of them had anal function 20 years. But I think, and my clinical impression was that from time to time, somebody who you thought was fine began to have trouble, whether it was some minor thing initially, like a bit of leakage or anal ulceration or something, that was then going to get worse and make life unsatisfactory in such a way that something needed to be done.
Yeah.
So I can't. I'm not anymore in the field to give you the latest figure on that. But I think there's no doubt, and the patient has to weigh up: is the so now is life with an ileostomy so bad? Some people say the cock ileostomy has come back in places like Germany and so on as a primary option, or
Yeah.
Scandinavia. So, but always felt right up to when I no longer was sort of reading the literature that there was nothing like that. The majority of patients having an ileal-pouch operation done by somebody who's got sufficient amount of experience and competence had a very good chance, the best chance, I thought,